Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. And welcome everybody to today's program. So you've been told you need radiation therapy with Dr. Chowdhary. I'm Katie Armsby from Cancer Support Community Atlanta. If this is your first time joining a Cancer Support Community Atlanta program, we welcome you. We invite you to visit our website, cscatlanta.org, where you can see a complete list of all of our free virtual and in-person oncology programs offered. These include support groups led by licensed mental health professionals. We have stress reduction classes. We have some gentle yoga classes, some breathing technique courses. If you're looking to reduce anxiety, we encourage you to connect to that program. We also have nutrition seminars that happen monthly, along with some cooking demonstrations. And we do offer a Nutrition 101 class, both in person and virtually. So if you're preparing for treatment or in treatment and have questions about eating and nutrition and some of those goals, we encourage you to join one of our monthly seminars. And then, of course, we have education programs like these. If you know somebody who missed today's live event, we do encourage you to, again, visit that website, cscatlanta.org, where you can find a recording of today's program. Probably it'll be up next week, and we'll also email it out to everybody as well. And if you visit that website, you can see a complete list of all of the programs offered and additional information on times and dates. So we're so excited to have Dr. Chowdhary here for today's program. Dr. Mudit Chowdhary is a board-certified radiation oncologist with experience treating a wide variety of disorders. He has a special interest in the treatment of genitourinary, lung, and breast cancers, as well as benign diseases. As a physician, he believes in providing cutting-edge, personalized, and compassionate care for his patients. Dr. Chowdhary is committed to building relationships and trust with his patients by providing his undivided attention and spending as much time as they need during their office visits. Dr. Chowdhary currently practices in Atlanta, and in his spare time, he enjoys spending quality time with his family, playing tennis, and rooting for the Georgia Bulldogs. And coming off of this weekend's high win against Florida, we're excited to welcome you to today's program, and I will pass it off to you to begin today's presentation.
Thanks so much, Katie. Thanks for having me and letting me speak on y'all's behalf. And before we get started, really just wanted to introduce myself a little bit. So I grew up in South Georgia in a small town in Valdosta, Georgia. I went to undergrad at the University of Georgia. I'm a proud Bulldog before going to medical school at Mercer University in Macon. And then I ventured out of the state and I went and got my training first in New York City and then my residency in Chicago before finally moving back home now, or as close to it as I can, to in Atlanta with my family, my wife and kids. So what we're going to talk about today, we're just going to start off with an introduction on radiotherapy. We'll go over the process and workflow for what patients would experience. We'll cover some of the common side effects that are experienced during treatment and ways to manage them. And finally, we'll go through recent advances in radiotherapy and how it may impact your care. So when I first talk about radiation therapy, this is what I feel like people usually think they're going to get. They think they're going to maybe melt, or maybe they might think that they're going to come in and turn really radioactive. But that's actually like really far from the truth. This is kind of what real modern radiotherapy really looks like. It's actually really highly technical field, highly precise. We treat you with a machine called a linear accelerator, which produces really high energy to treat you with. So nothing radioactive. You're just in a wide open room and you lay flat on a table and let our machine shoot those invisible X-rays at the area that it needs to go. So I consider radiotherapy one of the a highly effective treatment for cancer. It's considered one of the pillars of cancer care. This figure is from the National Cancer Institute. And really, you can see that that it's been around for a really long time, and it even predates chemotherapy. 2/3 of all cancer patients end up receiving radiotherapy for either curative or palliative intent. We're used from head to toe, whether it's from brain cancer, head and neck cancer, breast cancer, lung, GI, GU, GYN, lymphoma, you name it. There's a role for radiation therapy in that type of cancer. And interestingly, that's not all we do. There's a wide array of benign diseases that we're able to treat with low-dose radiotherapy. In fact, 1/3 of all radiation treatment in Germany is used for non-cancerous indications. I won't go through all these things, but I just like to kind of give a brief overlay of like when radiation was discovered in the early 1900s. It's advanced significantly to what we do now, to where we can give really high dose radiation therapy very precisely to ablate cancers. So from humble beginnings to really advanced techniques that we're able to offer our patients. There are various types of radiation therapy that exist. These are the three main ones. And so, the first form is external beam radiation therapy. And that, really is referring to using a machine to deliver energy inside your body from the outside. There's also something called brachytherapy, which is what really is internal localized radiation. So we use either a device or directly implant something within an organ where it can deliver actual radioactive sources directly to a tumor. And then lastly, there's something called radiopharmaceuticals, and that's where we inject something inside the bloodstream, and that can spread throughout your body and get to places where it couldn't otherwise. But by far, the most common form is external beam radiation therapy delivered in the form of photons or X-rays. And so that's kind of what I'm going to focus this talk on. So how does radiation therapy actually work? So we're damaging the DNA within cancer cells, and that destroys a cancer cell's ability to reproduce, resulting in cell death. When the damaged cells are destroyed by radiation therapy, the body naturally eliminates them. And as you can see here, and normal cells can also be affected by radiation therapy, but also each time you treat them, they're able to repair themselves. But cancer cells lack that same ability to be able to do that. And over time, with each treatment, they end up dying progressively. Again, modern radiation therapy is another example of a treatment room. It's very precise. We're able to be very conformal around the area we need to target. It's very accurate. We have onboard imaging to make sure that the area that we want to treat is actually going to receive treatment. We're able to provide a very high dose to tumors while being able to limit dose to normal tissues nearby. So how is it prescribed? And so I really think of it in four different things. So I think about it in dose, fractionation, technique, and location. So when we're referring to dose, we're talking about what is the total amount of energy that is being administered to get rid of this cancer. We're talking about fractionation, that we're talking about how many treatments are required to reach that prescribed dose. So for example, let's say 30 gray, and how many treatments do you want to get that 30 gray inside the body. We also talk about technique, which is really referring to planning style. And so that I'm going to go into a little bit further detail for your convenience. So historically, radiation infancy started in the two-dimensional era, and that's where we actually used chalk to draw out or outline the areas we wanted treated on X-rays, and then made physical lead cutouts to accomplish that goal. So it was really high tech at the time, but now looking back, it was very primitive. We were then able to develop 3D conformal radiation therapy. And this technique uses a CT scan to create a 3D picture of the tumor, as well as the surrounding anatomy. we're able to choose the number and angle of beams to conform to a target, and this allowed for significantly improved precision and decreased normal tissue exposure compared to what we used to do. More recently, we've adopted a technique called intensity modulated radiotherapy, or IMRT. This is a highly sophisticated form of 3D conformal radiation in which we utilize sophisticated computer software to choose the appropriate number and beam angles required to safely deliver the specific radiation dose. You can see here on the top right, there's these things called multi-leaf collimators within the head of the machine that are constantly moving. This allows us to dynamically modulate the dose intensity around the desired shape. And you can see here on the bottom example on the left, where a patient's head, the red dose is the high dose to the tumor. And when you're doing with 3D conformal, you can get all your dose there. But you can see there's a lot of low dose spread as evidenced by the yellow. But IMRT, really, you can see how it's carved much more effectively thanks to these multi-leaf collimators and computer softwares. And this is an example you can see in a patient case. So this is a rectal cancer patient. On the left is being treated with 3D conformal radiation. You can see there's 4 beams coming, one from the front, one from the back, one from the right, and one from the left. They produce a really good dose distribution around the tumor. But when you look on the IMRT side on the right, you can see here how like the high dose, the 100% of the dose, the orange line, as well as the 90% dose, the dark blue line, hugs that irregular light blue pattern much better than what you would see on the left. And similarly, the low dose, the green line, and you can see that it's significantly out of the bladder sitting in front, where on the left, you can see it was definitely getting a lot more dose. And so that's why this technique has really changed the game for a lot of patients. You may have also heard of a planning technique called stereotactic radiation therapy. This is also a type of radiation, but where we deliver an extremely high dose to a very specific target. It also utilizes IMRT planning technique, but just using a very narrow beam. So you can kind of see here, like the yellow line, the beam is coming out. And so I think of when we're doing stereotactic radiation as closing the shutters within the machine head. This allows us to produce this really narrow beam coming into the patient to a very small target, very precisely. When it's within the brain or spinal cord, we refer to this as stereotactic radiosurgery. When it's anywhere else in the body, it's called stereotactic body radiotherapy, or SBRT. In other places, call it SABR, or stereotactic ablative radiotherapy, but they're the same thing. I know, we have too many acronyms, I get it. This is a case of stereotactic radiation examples. This is a patient with a brain metastasis. I've just roughly highlighted it with the drawing tool on here for your convenience, that we were able to treat with very high dose radiosurgery. And you can see the high doses very conformally surrounding that target. And you can see how, because of that, the rest of the brain is getting almost zero dose exposure. And that's, again, like been an awesome technique to be able to provide to our patients. And finally, like I mentioned, the fourth part of how it's the RT prescribed is the location. So which body site are we giving treatment to? When you combine that all together, you may hear your doctor saying, oh, I'm going to prescribe you 20 gray in 5 fractions using 3D conformal radiotherapy, let's say to your pelvis. So let's go through the process and workflow of what patients would experience during this time. And it's usually like a 2-week process from start to finish before you get started, and we'll go through each step. It all starts with a consultation. Here for me specifically, it's at Northside Hospital, Atlanta. We first determine if you're a good candidate for radiation therapy based on your cancer characteristics, your health status, your goals and desires. If you are in agreement with that, then we do something called a CT simulation or a planning session. This is a specialized CAT scan in the treatment position, and we often use special immobilization to help target the area of interest. You can see in this picture, this patient is wearing what we call like a vac lock, which is kind of like a bean bag underneath their bag. You fill it up with air, and it fixes and conforms to your specific body shape, so you can lay in that mold every single day very easily. Sometimes to actually not just a regular CAT scan, we use what we call a 4D CAT scan, where we're able to actually record your lungs in action or your abdomen in action. So that way, for example, in a lung cancer case, so you can outline in red, we're able to mimic the tumor's movement and make sure we treat it while you're breathing. After that, we actually start creating the radiation therapy plan. Oftentimes, we fuse other scans you may have gotten, such as like a PET scan, which you can see here, this fire red signal that's overlaid over the actual tumor. And during this process, we identify the cancer, we identify all healthy organs, and then we work on arranging the beams in such a way to maximize dose to that cancer while minimizing dose to the healthy tissues. And so your end product ends up looking something like this. You can again see the tumor itself is getting all of the radiation dose, the high dose directly in the center of it. A little bit of low dose goes to the surrounding tissues, but you can see here we've taken care. In this specific example, you can see the spinal cord is not getting dose, your heart is not getting any dose, your airways, your opposite lung. And so really that's where all the bulk of the planning time is spent. Following the creation of the plan, we actually go through what we call quality assurance. This begins with a peer review process amongst a group of other radiation oncologists and other team members, where we discuss the case, show what we've done, make sure that everyone kind of agrees that this is a safe and effective way of doing things. Everyone agrees to that. Physics team then tests the accuracy of delivery. They often use what we call like phantoms that mimic like the human body and make sure that the plan we've done on the computer can actually be administered to something in reality. And so the physics team works hard on making sure that that's safe. Finally, once all of that is done, we actually turn the beam on. You come in and get treated, and then for a set period of times based on your specific tumor and what it needs to be treated effectively. So let's talk about some side effects that you may experience during treatment. So we usually, when we're referring to these, they're typically localized to the area that is being treated. And so, for example, in breast cancer, you may notice like some skin redness and breast swelling. You can notice your skin could get a little darker or lighter. Well, in contrast, if you're treating the head and neck area, you could have some mucositis or some pain in that area. You could have some dry mouth, maybe some loss of taste. And again, contrast that to the pelvis, where you can maybe develop some diarrhea or urinary frequency urgency. The most common systemic side effect that's common to all of these is, for whatever reason, patients getting radiation therapy end up getting tired during therapy, usually a few weeks in. And in the past 100 years, we still haven't fully understood exactly why that happens, but it certainly does. I typically describe it as you need like an extra nap during the day or so, but sometimes it can definitely be a little bit worse than that too. Most of these side effects, if they happen, they begin in the second to third week of treatment, and they typically resolve within a few weeks after your final treatment. We make sure to monitor you throughout your treatment course. We have scheduled once weekly on-treatment visits, or OTVs, and that's where we kind of evaluate you. We ask you questions, and I really like to emphasize that please share what you are feeling during those times. You know yourself way better than anybody else does, and we want to do what we can to make sure you feel better and make sure you're not feeling unwell. And a good example I like to give from this is a slide that I've borrowed from a patient advocate friend of mine, Jill Feldman. She shares this slide, and when you look at this picture, you'd think the team and others looking from the outside looks at it and thinks she looks great, right? Like she looks awesome. But how she actually feels sometimes, like, she's been on chemotherapy for a long time, like, has had radiation, but, she's had so many side effects from all of her treatments. And so even though she looks great on the inside, on the outside, only she knows what she's really feeling. And tolerable is really very relative. And so it's really, we really hope that we can earn your trust and you can share how you're feeling with us during those on-treatment visits. What do we do to try to mitigate some of these side effects? Well, for certain areas, I like to prescribe prophylactic ointments. And specifically, like in this case, this is a steroid cream that I prescribe. It's been shown in a randomized trial that this significantly prevents the chances of getting like the skin redness or any burns or anything like that on your skin. And so before you actually start treatment, I try to prescribe this. Recently, this was a study that was published that showed that using something called a Mepitol film just acts like as a mild barrier between your skin and the radiation therapy. And it also has been shown to prevent acute radiation dermatitis and breast cancer. This is another option for specific patients. Sometimes we'll prescribe you prophylactic medications depending on the area of the body we're treating. So for example, like anti-nausea medicine, maybe some acid blockers, maybe some Flomax if we feel like you're going to get some urinary problems. I really like to encourage exercise during treatment. So studies have shown that whether it's yoga or aerobic exercises, resistance training, patients that do anything like this while they're getting treated, they've noticed that they have significantly fewer side effects and improvement in fatigue and quality of life. So I really try to highly encourage that. I try my best to try to give some of the flyer with the resources to the cancer support community. I know they have a lot of good classes in place that are excellent resources for patients in this case. And finally, sometimes we're able to employ those advanced planning techniques that we went through, whether it's IMRT or stereotactic radiation. We try to focus on organ avoidance to the best of our ability. And those have been shown now that they can significantly reduce the chances of getting some late side effects. All right, so what are some recent advances in radiation therapy? Well, I like to think the general theme behind this is that less is more. And by what I mean by that is fewer treatments, like maximizing your benefits in fewer treatments. So let's start with breast cancer. So when I first got into the field, I learned that the historical way that patients were being treated was with whole breast radiation therapy for 5 weeks. But by the time I started, it had been reduced to 3 weeks. And now, most recently, we found that even 1 week of whole breast radiation therapy is able to be equal to 3 weeks of treatment. And so that's really made the treatment so much more convenient for patients. And so this is something I try to employ for all early stage breast cancer patients to the best of my ability. Similarly, we found that maybe for right candidates, we don't even need to treat the entire breast. Studies are now showing that treating the partial breast in 5 treatments is also equal to 5 weeks of everyday whole breast radiation therapy and with significantly fewer side effects. So again, for the appropriate candidate, this is something that I try to employ as seen in this treatment plan. We're also finding that there's a really increasing role of radiation therapy in what we call oligometastatic cancers. Now, what we mean by that is that once the cancer has left the primary site, we call it metastatic, but that not all metastatic cancer is made equal. So like patients who have like 1 to maybe 4 areas of disease outside of their primary cancer, they live significantly longer than, let's say, someone who has 20 lesions inside their body. And we're finding that doing aggressive treatment to those areas of metastases with the stereotactic radiation therapy has actually been shown to significantly improve overall survival, as well as reduce the chances of the cancer progressing in patients. This has been a really exciting development for patients and for us as physicians. And is now currently being tested. And can we move beyond the oligometastatic to the widely metastatic setting? Can we still achieve these great outcomes? In prostate cancer, there's been a lot of recent updates. One big one was now we have in one of the largest randomized controlled trials that in prostate cancer with 15 years worth of outcomes between surgery, active monitoring, or radiation therapy. We're finding that the cancer control rates and survival between radiation therapy and surgery are actually equal. And there is a different side effect profile between them, but it's great to see amazing long-term results for these patients, showing that there is a non-invasive option if desired. Recently, two very important trials just came out from the United Kingdom. The first one, PACE-B, this randomized patients who were normally getting 4 to 7 weeks of once daily radiation therapy and compared them to those patients receiving stereotactic radiation therapy in only 5 treatments. And they found that the cancer control rates was exactly the same. There was only a mild increase in side effects. So this, again, is showing that we can achieve great outcomes in much fewer treatments for patients. The second trial was called PACE-A. This randomized patients between surgery versus stereotactic radiation therapy. And so far, they've reported their toxicity results, and they found that, again, there's different toxicities between the two. Surgery has higher rates of using pads, as well as lower sexual function when compared to radiation therapy, while radiation therapy has higher GI toxicity. But in combined, these two PACE studies showed that stereotactic radiation may be the way to go for the vast majority of early stage prostate cancer patients. And finally, I want to quickly talk about non-cancerous things. So we're finding that low-dose radiation therapy may actually play a role in some painful musculoskeletal disorders. And so one of the things I'm going to highlight is osteoarthritis here. So this is a paper that I actually was able to participate in, where we reviewed the use of low-dose radiation therapy in arthritis. And what we're really seeing is that 30,000 patients per year in Europe have been receiving this treatment for the past 20 years with great benefits. And in summary, about 60 to 90% of patients are reporting some form of pain relief with this low-dose radiation therapy. Typically, the response is seen within 6 weeks after finishing radiation therapy, and you can see continued improvement over time for up to 2 years. The ideal candidates for this are those that are greater than 50 years old, refractory to physical therapy or conservative therapy, and that have been requiring NSAIDs and or steroid injections just for pain relief. The treatment logistics for this is we treat them in 6 total treatments to very low doses, less 0.5 gray per session. You get about 2 treatments per week, 1 time per day. And each treatment is about 30 seconds. So we were able to start the first ever low-dose radiation therapy program in Georgia recently. So this is a patient's bilateral hips that have been bothering him for quite some time without any relief with medicine or steroid injections. We were able to treat the bilateral hips, and within 6 to 8 weeks of being treated, he had a 50% reduction in pain and was starting to walk 3-4 miles. Similarly, this is a patient's hand that I treated, very bad hand arthritis, was preventing from activities of daily living. We were able to treat with 6 treatments. And again, at 8 weeks after, we're seeing a significant reduction in pain. And she's very happy with it so far. And we're happy to say that we're up to close to a dozen patients now. So this is a very exciting thing that we're able to offer patients. And so finally, I just wanted to end by sharing my contact information. And so I practice here at Northside Hospital in Atlanta. You have our office phone and my email if you need to contact me for any questions, or as well as our website where you can find me. And so thank you so much for taking the time to listen to my talk. And, I'd love to answer any questions if you have any.
Thank you, Dr. Chowdhary. That's a lot of great information. Thank you, everybody. We already have some questions to jump to in the chat box, and a lot of them pertain to kind of who are candidates for different types of radiotherapy. So I'm going to jump to one that talks about specifically proton therapy. Do you know what makes someone a good candidate for proton therapy? Is it a specific cancer, or what kind of would lead a physician to suggest that?
Absolutely. Proton therapy is a very exciting branch of our field. It's being tested in lots of different cancer types. And as of right now, the best candidates for it are those who have received radiation therapy in the past and for some reason have to have a retreatment in that same exact location. Others that do really well with proton therapy are children, and found that that's been shown to reduce side effects in those patients. But for common cancers, like for the first go around, like such as breast cancer or lung cancer or prostate cancer, the data hasn't really shown any improvements and outcomes. And so for those, we try to advocate only receiving proton therapies if you're on a clinical trial.
Okay, thank you. And I think towards the end of the presentation, you were talking about some of those abbreviated treatments, some of the newer stuff that's coming out. I know you had mentioned that's for early stage breast cancer. Is it specifically just for early stage breast cancer, or are there other cancers open to that?
Yeah, so for early stage breast cancer, most patients will be good candidates for at least the 1 week whole breast radiation therapy. There's some patients that will also be good candidates for the partial breast, but there's very specific criteria we look for, specifically like the patient's age, their tumor size, make sure that the margin status was above and beyond what we consider negative, and that we can easily target it on a CAT scan. And those are kind of what we're looking for to determine if you can get 1 week partial breast versus 1 week whole breast. And more locally advanced breast cancer, like when it's after a mastectomy, for example, or if lymph nodes are involved, currently the standard of care is still 5 weeks, though there's been a lot of recent evidence showing that 3 weeks in those more locally advanced settings may be sufficient. And that's something that I have treated with for the right candidates plenty of times over the past year.
Okay, and I think part of that you had mentioned, depending on, a question was if someone had their tumor removed, would they be a candidate and they still were suggested for radiotherapy? Would those abbreviated sessions be an option for them, or do they need to go probably the longer route?
Yeah, and it's tough to say. It really just depends on the specific cancer. Like again, and breast cancer, I'm coming back to that. Like, the patients that we're usually treating, they've all had surgery before, so the abbreviated courses are still eligible after the surgery. In something such as like prostate cancer that we were discussing, the abbreviated courses are a form when you're choosing radiation as your primary treatment option. If for whatever reason you get surgery and you have to get radiation therapy despite the surgery, then we are looking at shorter courses, but by that we mean decreasing from, like, let's say 8 weeks of radiation down to 6 weeks. We're still making our way down from the longer courses in something like prostate cancer. Similarly, in lung cancer, after we're talking about the abbreviated courses. Again, that's primarily like as a way to treat your cancer definitively in lieu of surgery. So it really just depends on the specific cancer type and its characteristics when we look at the pathology report.
Okay. And when you were talking about you said it was a 2-week process, I think, before getting started, when you were walking us through that. And the initial part was kind of how somebody initially presents. Are there any characteristics that kind of eliminates someone as eligible for radiotherapy?
Yeah, so the best case scenario is you come in and your cancer is just so low risk that it doesn't require any treatment that makes us all happy. But other characteristics typically is like, let's say, you can't lay still on the table. We can't recreate the treatment position. Sometimes there are some disorders that we have to be a little bit more careful about, like connective tissue diseases, for example. If there's like a pacemaker, that would be within the field. That's something we would look for as well. Those are kind of the things that we look in during the consultation process.
Okay. One participant had a question. Can you talk about SBRT versus proton as far as efficacy?
Yeah. So, proton therapy kind of just really refers to like the source that's being used, right? Like, so SBRT is typically used as a technique. And you can use X-rays to deliver SBRT, or you can use protons to deliver SBRT. It's really referring to that giving a really high dose of radiation therapy to a very small area in very few settings. And so, you can deliver SBRT with proton therapy, but as of right now, that's still considered more experimental and really is being pushed by our field to really enroll on a clinical trial if you're trying to do the same technique with protons.
Okay, thank you. And then we did also have a question for internal radiation therapy. Is there any discussion you guys have with patients about being radioactive at any point for a certain period of time? Or I guess what kind of discussions do you have?
Yeah, I mean, it definitely depends on the type of internal radiation therapy. So, for example, with GYN cancers, when we're doing brachytherapy, oftentimes we're temporarily inserting a device inside where we won't need the radioactive source to go to. We connect that to what we call like a afterloader, which houses radioactive seeds, and when we turn the machine on, it temporarily transmits the seeds through some cables to the area we want it to go to. And then when the treatment is done, it's vacuumed back out of your body, back into the afterloader. We then disconnect the cables and remove the device. So then, for example, you have nothing inside your body, and so you're not radioactive. And we do similar technique when we're doing prostate cancer brachytherapy. It's called high dose rate brachytherapy. But in some cases, like for example, in prostate cancer, they still do insert radioactive seeds directly into the prostate, and that does require a little bit of precautions. But even then, the dose administered has such a rapid fall off that it doesn't really go beyond like a few millimeters to centimeters beyond where it's inserted. So being around other people is typically not an issue.
Okay, thank you. And we had a question related, I think, towards the end of the PowerPoint. And I'm not sure if you would know this or if it would be a question for someone else in the clinic. Do you know if insurance covers RT for OA?
Yes, it's 100% covered by both private insurance as well as Medicare. And that's something that we always make sure we get the authorization from the insurance companies before we would ever start your treatment, because we don't want you to incur any additional fees or anything like that. But thus far, we've had a 100% reimbursement rate for you for this type of treatment.
Okay. And this question, I think, talks about before being treated. Who within the cancer team determines how many treatments are needed for a particular site?
Yeah, it's usually dependent on the radiation oncologist that you see. We do our best to try, at least in our group, to follow like the National Cancer Guidelines and try to really minimize the amount of treatments that we would need to give to you. But ultimately, it ends up being a decision between the radiation oncologist you see as well as yourself as a patient, giving your input and making an informed decision on what are the different options.
Okay, and then this question discusses side effects. Does RT make you increase your chances of any kind of long-term side effects? And is there anything you should do to be monitoring any of that ongoing?
Yeah, so definitely we will continue to follow you up over many years to make sure you're not developing any side effects. And it kind of, again, it just depends on the body area that's being treated. So for example, in breast cancer, like there's a late things that could happen is, you could get some chest wall tightness or discomfort that could require, for example, physical therapy or occupational therapy. And head and neck cancer, really monitoring for, like how long is dry mouth going to occur for and last? Is your taste returned? Are you going to have any neck fibrosis as the tissues are recovering from the treatment? One thing we also caution patients on is because radiation can cure cancer. There's a very small chance that it can also cause a cancer, and that risk is typically less than 1% throughout the patient's lifetime. But to a patient, if that does happen, that's a lot to go through. And so it's something, again, we make sure to monitor you throughout treatment, give you advice as needed, whether it's with specific medications or PTOT, et cetera, that you would need when we see you during follow-up.
Thank you. I think this kind of question goes back to kind of who may be a good candidate for RT. This question is there any way to get an idea of who might be more prone to pneumonitis before getting nodules in the lung radiated?
I think usually we really are most concerned about patients with underlying like bad lung disease, such as like if you have interstitial lung disease to begin with. That's a high risk category to begin with, and something that we have to be very cautious about. Some of the other things that really it looks for when you're looking at your plan is trying to get the most advanced technique possible, because we're showing that there's lower radiation pneumonitis risks when you use, like, for example, IMRT compared to when you use 3D conformal. And then similarly, when we are able to pinpoint it even further in the right candidate with SBRT, we can further reduce your lung volume getting radiation therapy. So it really just comes down to the patient characteristics, the physician you're with, as well as the facility, like what type of machine and treatment capabilities do they have.
Thank you. And this question is again about side effects. Can you tell me about the chances of getting lymphedema after having an axillary dissection?
Yeah, that's a great question. Recently, there was some great data published from the Harvard group, and they looked at patients who had breast cancer surgery, whether it was lumpectomy, with or without axillary sampling. They also looked at mastectomy, with or without axillary lymph node dissection. And then they also looked at those groups, did they receive or not receive radiation therapy? And they were able to actually track them for many years. And they found that the biggest risk factor for getting lymphedema was the extent of axillary dissection that you received. And so the fewer lymph nodes that were removed, the lesser chance there was of developing lymphedema. And that when they looked at those patients plus or minus RT, they found that the addition of RT, thankfully had a minimal impact on increasing lymphedema. And so really the conclusion was that the radiation therapy to the axilla has become safer and safer, and really we're looking for the extent of lymph node dissection when seeing who's at high risk for that.
Okay, thank you. And we have a question. I think this is kind of a specific one. In the specific case of leptomeningeal metastasis, what would RT look like if a patient is considered a good candidate? And a follow-up question to that, are there any specific techniques currently being used or research to prolong survivability?
Yeah, that's a great question. And so for that specific scenario, usually we're talking, there's two options. You can either do something called craniospinal irradiation, which means treating the entire brain as well as the spinal cord neuroaxis. The alternative approach is you spot treat like an area that is symptomatic. And again, it just depends on the capabilities of the machine and how healthy the patient is. Because the CSI has significantly more toxicities than doing, the focal treatment. If a patient, let's say, is healthy enough for the craniospinal irradiation, there is some actually recent provocative data, a phase 2 trial, I believe, that was showing that proton craniospinal irradiation tended to be better than spot treatment with X-rays. And so that was very promising and exciting results. They need to, the update to that is that I think the follow-up would be, they didn't compare proton CSI versus if we did it with photons, like regular conventional X-ray treatments, and whether it was the increased area that was receiving dose radiation that led to the improved outcomes, or was it the actual proton itself? And so that's an area that's also currently being investigated. That's a very good question, though.
All right, I think we're wrapping up all of our questions. If anybody has any last questions, feel free to enter them into the chat box. We had some really good conversation in the Q&A, and Dr. Chowdhary, you shared so much great information. We do appreciate it. While we wrap up, I do want to also share that Cancer Support Community Atlanta again hosts a Nutrition 101 seminar. So if anybody is going through radiation therapy or looking to connect to information about nutrition to prepare them for it, we invite you to visit our Nutrition 101 program. That's November 6th, and we'll also be hosting one on December 4th as well, 1 to 2 p.m. We offer it virtually and in person, so you're welcome to visit our website to find out more information. And I want to remind anybody, if you know someone who would appreciate Dr. Chowdhary's program, please feel free to share the video link with them. That will be up on our website probably next week. So again, thank you everybody for joining us. And before we close out, I do want to throw it back out to you, Dr. Chowdhary, to share any final thoughts.
Just thank you guys so much. These are amazing questions, and I really appreciate y'all's participation and for coming out to see me. And thank you, Katie, and the Cancer Support Community for the opportunity. And it's been a pleasure working with y'all, and thank you for providing a lot of great resources to our cancer patients. And please feel free to reach out if y'all need me for anything.
Thank you, and thank you, everybody. We hope to see you again soon. Everybody take care.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.